When you picture chronic kidney disease, you probably see a 70-year-old managing decades of diabetes,
Hmm.
right? You picture someone whose organs are just kind of wearing down after a long lifetime of systemic wear and tear.
Yeah, that's the standard image.
But right now, across the globe, thousands of children, I mean, some just weeks old, some not even born yet, are facing this silent, progressive shutdown of their vital organs. It's a reality that completely shatters our conventional understanding of who gets sick and why.
It really forces a massive paradigm shift, you know? The source material we're examining today, which is this incredibly comprehensive clinical presentation by Dr. Izazuba Ejioma on pediatric chronic kidney disease, or CKD, it highlights a staggering reality.
Yeah, the numbers are wild.
Right, so we're looking at a global prevalence of roughly 18 per 1 million children. And depending on where you look, the incidence of total organ failure is climbing. The data specifically points out that in Nigeria, 2.5 children per million of the population will develop chronic renal failure every single year.
And behind those statistics is just a catastrophic ripple effect. If you're a parent listening to this, or simply someone trying to comprehend the sheer scale of pediatric illness, the implications are devastating.
Absolutely.
Because when a child's kidneys begin to fail, it doesn't just isolate to their lower back. It derails their bone growth, it poisons their brain, it starves their blood of oxygen, and honestly, it bankrupts families due to the astronomical cost of management.
Which is why the central thesis we're working with today is that early detection isn't just like a medical best practice, it is the absolute unyielding front line of defense. Because once the damage crosses a certain threshold, it becomes totally irreversible.
So to understand why that threshold is so dangerous, I think we have to completely reevaluate what we think the kidneys actually do. There's this persistent, almost elementary school level misconception that the kidneys are nothing more than biological coffee filters.
Yeah, people assume their only job is to turn bodily waste into urine.
Which they do, of course. The elimination of metabolic end products is a primary baseline function. But trying to conceptualize the kidney as just a waste management system is like calling a smartphone a calculator.
That's a great way to put it.
I mean, it does the math, sure, but you're ignoring the GPS, the camera, the internet connection. I was reading through the baseline functions in the presentation, and the kidneys are essentially the body's central chemical balancing plant, the water reservoir management system, the blood pressure command center, and a major hormonal factory all rolled into two bean-shaped organs sitting against your back wall.
And that multi-system responsibility is exactly why their failure is so catastrophic. Let's break down that chemical balancing plant for a second. They constantly monitor and adjust the balance of water and electrolytes.
Right.
So if you drink a gallon of water, your kidneys increase output so your cells don't swell and burst. If you eat a massive amount of salt, they have to excrete the excess sodium.
They keep everything in perfect harmony.
Exactly. And beyond that, they maintain our acid-base balance. You know, the human body is constantly generating acid just by existing. Metabolizing food creates acidic byproducts.
So the body's just making acid all the time.
Constantly. And the kidneys are responsible for manufacturing bicarbonate, which is essentially an internal antacid, to neutralize the blood. They also eliminate foreign materials like clearing medications and environmental toxins from our bloodstream.
That alone sounds like a full-time physiological job. But the part of the presentation that really grabbed my attention was the endocrine function. The kidneys literally manufacture hormones that dictate the behavior of other organs far away from the urinary tract.
The endocrine role is incredibly profound and, frankly, almost entirely overlooked by the general public.
Yeah, I had no idea.
For instance, the kidneys are responsible for the final activation of vitamin D.
Wait, really? I thought that was the skin in the sun.
Well, you can absorb all the sunlight you want and drink all the fortified milk you can find, but if your kidneys don't perform the final chemical conversion, your body cannot use that vitamin D to pull calcium into your bones.
So a kidney problem is instantly a bone problem.
Instantly. Furthermore, they produce a hormone called erythropoietin, or EPO. EPO acts as a chemical messenger that travels to your bone marrow and orders it to manufacture red blood cells.
Meaning a kidney problem is also instantly a blood problem. You stop making the signal, you stop making the red blood cells, and the child develops profound anemia.
And finally, they produce renin. Renin is the foundational enzyme in a massive cascade that regulates systemic blood pressure. If the kidney senses a drop in blood flow, it releases renin, which triggers blood vessels across the entire body to constrict, driving blood pressure up.
So let me get this straight. If the kidneys go down or become confused by internal damage, your bones dissolve, your blood count plummets, and your blood pressure goes completely haywire.
That is exactly what happens.
With all of that immense responsibility sitting on these organs, how does Dr. Igioma's presentation actually define the breaking point? Because pediatric chronic kidney disease can't just be an upset stomach or a temporary infection. There has to be a hard clinical line in the sand.
The clinical definition is precise, and it hinges entirely on the concept of time. Pediatric CKD is defined as a persisting and progressive disorder of the two kidneys lasting for at least 3 months.
Why 3 months? What happens at day 90 that doesn't happen at day 20?
The 3-month duration separates an acute kidney injury from a chronic disease. A child might suffer a severe bout of dehydration or a heavy bacterial infection, causing their kidneys to shut down temporarily.
Okay, so like a temporary glitch.
Right. In an acute scenario with proper medical intervention, the tissue can heal and the filtering power returns to baseline. But if the abnormalities persist for 12 uninterrupted weeks, the medical consensus is that structural scarring has occurred. The architectural damage is permanent and progressive.
So what are the actual manifestations of that damage? If a pediatrician is trying to formally diagnose this, what criteria are they looking for to prove it's CKD?
The criteria fall into 2 distinct pathways. The disease manifests as either structural or functional abnormalities, or it manifests as a pure mathematical drop in filtering power.
Let's take the structural pathway first. What kind of abnormalities are we talking about here?
These are physical markers of kidney damage that can exist even if the kidney is still technically managing to filter the blood. They are usually spotted as urinary abnormalities, the most critical being proteinuria, which is the leakage of protein into the urine.
We'll get into the mechanics of that later, but protein does not belong in the urine.
Period. It absolutely does not. You might also see blood in the urine or structural deformities visible on an ultrasound or MRI, like cysts or malformed ureters. If those abnormalities are present for 3 months, it is CKD.
Even if the filter itself is still working at normal speed.
Even if it's working at normal speed, the physical damage is the defining factor for that pathway.
Okay, so what is the second pathway, the mathematical one?
The second criterion is having a glomerular filtration rate, or GFR, of less than 60 milliliters per minute per 1.73 meters squared for 3 months or more. And this applies whether there is visible structural damage or not.
Yeah, FR. This acronym is everywhere in the source material. It's the central metric for staging the disease. Let's really clarify this for anyone who isn't a nephrologist. GFR is essentially the speedometer of the kidney, right?
That is a very accurate way to visualize it.
It measures how many milliliters of blood your tiny cellular filters, the glomeruli, can scrub clean of waste every single minute.
Exactly. The higher the GFR number, the more efficiently the blood is being cleaned. A robust, healthy filtering system handles a large volume of liquid quickly. A damaged, clogged, or scarred system slows to a crawl.
Which brings us directly to the KDO-QI staging system. This is how doctors map the decline of the kidneys from mild damage all the way to total failure. It's a 5-stage system based entirely on that GFR speedometer.
And the staging is crucial because it dictates the entire management strategy. Stage 1 is defined as kidney damage, perhaps structural or evidenced by protein in the urine, but with a normal or even increased GFR. That means a GFR of 90 or above.
Hold on, I have to stop you there because when I first read that, my brain completely rejected it.
Yeah.
Stage 1 means you have kidney damage, but your filtration rate is normal or increased.
Yes.
How can a child have a diseased organ, but that organ is working faster and harder than a healthy one? It sounds like a paradox. Shouldn't a high filtration rate mean the kid has super kidneys?
It is a brilliant, terrifying paradox of human physiology. It introduces a concept called hyperfiltration. To understand this, you have to look at the kidney at the microscopic level.
Okay, zoom in for us.
You have roughly 1 million tiny filtering units called nephrons in each kidney. When a disease attacks, whether it's an infection, an autoimmune response, or a genetic defect, it kills off a percentage of those nephrons.
So let's say 20% of the nephrons die. The remaining 80% are just sitting there.
Right. But the body still has the exact same amount of waste to clear every day. The circulatory system doesn't care that the kidney is wounded. It keeps delivering the same volume of toxic blood. So the kidney compensates.
How?
The remaining healthy nephrons don't just pick up the slack, they physically mutate, they undergo hypertrophy, they enlarge. The blood vessels leading into these surviving nephrons dilate widely, allowing a massive surge of blood flow.
I picture it like a massive factory floor with a team of 100 workers handling a conveyor belt.
Mm.
A gas leak takes out 20 workers. The conveyor belt doesn't slow down.
Not at all.
So the remaining 80 workers go into an absolute frenzy. They are sprinting, sweating, pulling double loads, moving faster than they ever have in their lives just to prevent the factory floor from overflowing with waste.
That is precisely what is happening hemodynamically. The remaining nephrons redline their internal pressure. Because they are working so incredibly hard, the overall filtration rate of the kidney actually spikes. The GFR goes above 90. It looks, on paper, like the kidney is performing beautifully.
But it's an illusion. It's not a sign of super health. It's a sign of a biological panic attack. The remaining workers are holding the line, but at what cost?
At a fatal cost, which we'll uncover when we discuss the pathogenesis. But for staging purposes, this is why stage 1 is so deceptive. The high GFR masks the underlying architectural collapse. If you don't catch the protein leaking into the urine, you will entirely miss the disease until the workers start to collapse from exhaustion.
Which leads us to the subsequent stages. What happens when that compensation fails?
The decline becomes mathematically apparent. Stage 2 is kidney damage, with a mild decrease in GFR falling between 60 and 89.
The workers are getting tired.
Very tired. Stage 3 is a moderate decrease, with the GFR dropping between 30 and 59.
At this point, the waste is undeniably backing up into the blood.
Significantly. Stage 4 is a severe decrease, with a GFR between 15 and 29. The clinical manifestations become severe. And finally, Stage 5. This is end-stage renal disease, or ESRD. The GFR drops below 15, or the child requires active mechanical dialysis to survive. The factory is burned to the ground.
That trajectory is incredibly grim. But it begs the question, what lights the fire in the first place? If you're mentally reviewing the adults you know with kidney disease, it's usually decades of high blood pressure or poorly managed diabetes slowly calcifying the vessels.
Right, lifestyle factors over a long period.
But a 3-year-old hasn't had time to develop lifestyle-induced hypertension.
Yeah.
The root causes, the etiology, must be fundamentally different.
They are entirely different, and what standard pediatric texts, like Nelson Textbook of Pediatrics, will tell you which supplements Dr. Ichiyama's slides perfectly, is that the etiology in pediatrics is starkly bifurcated by age. There is a massive dividing line right around a child's 5th birthday.
So let's look at the under 5 demographic. If a 2-year-old is in stage 3 kidney failure, what attacked them?
In children under 5, the causes are overwhelmingly congenital or genetic. These are profound errors in embryological development. The child was quite literally born with the blueprint for failure. The presentation highlights a major culprit, obstructive uropathy.
Which implies a physical blockage somewhere in the plumbing.
Precisely. And the most prominent example in young males is a condition called PUV, or posterior urethral valves.
Explain the physical mechanics of that. How does a valve destroy a kidney?
Well, during fetal development, temporary membranes form in the urethra, the tube that carries urine out of the bladder. Normally, these membranes dissolve before birth. In a boy with PUV, those membranes persist, creating sail-like flaps of tissue inside the urethra.
So every time the fetus tries to urinate in the womb, these flaps catch the flow of fluid and balloon outward, blocking the exit.
Yes.
So the urine is trapped.
It is trapped under immense pressure. The fetal bladder has to squeeze violently against this blockage, causing its muscular walls to thicken massively. The urine then backs up into the ureters, the tubes connecting the kidney to the bladder, stretching them out like overinflated water balloons.
Oh, man.
Ultimately, that massive hydraulic pressure backs all the way up into the delicate tissue of the developing kidney itself.
The pressure essentially crushes the internal filtering tissue against the outer capsule of the kidney before the child even takes their first breath. That is horrific.
It is devastating. The architectural damage is done in utero. Another major congenital cause is renal hyperplasia or dysplasia. This means the kidneys simply failed to grow to their normal size, or the tissue developed chaotically. You are asking a child to survive on an organ that only has a fraction of the necessary nephrons.
It's like trying to run a massive corporate server farm on a single laptop battery. It's destined to overheat and fail. What about the genetic disorders mentioned? Polycystic kidney disease is on the source list.
Polycystic kidney disease, or PKD, is a fascinating and destructive genetic anomaly. It involves a mutation in the proteins that manage the tiny hair-like structures, or cilia, on the surface of kidney cells. When these sensors fail, the cells begin to wildly secrete fluid and replicate, forming hundreds, eventually thousands, of expanding, fluid-filled cysts.
So instead of a solid, tightly packed organ of microscopic tubes, the kidney turns into a massive cluster of water balloons.
Exactly. And as those cysts expand over months and years, they literally crush the adjacent healthy nephrons out of existence. The organ can grow to an enormous size, taking up a huge portion of the child's abdomen, but its functional capacity plummets to zero.
The presentation also lists congenital nephrotic syndrome and prune belly syndrome.
Yeah, congenital nephrotic syndrome is a genetic defect specifically in the podocytes, the microscopic filtering grates of the kidney. The grates are built with the wrong molecular structure, and massive amounts of protein leak out of the baby's blood from day one.
And prune belly.
Prune belly syndrome is a rare triad where a child is born with virtually no abdominal muscles, undescended testicles, and severe urinary tract malformations. Without abdominal pressure, the urinary system becomes stagnant and vastly dilated, leading to chronic infections and pressure damage.
Okay, so if we look at the under 5 group, the story is almost entirely about architectural flaws. Blocked plumbing, missing tissue, genetic cysts. But the source material notes a radical shift when we look at children over the age of 5. The diseases attacking an 8-year-old are a completely different landscape.
They are. For older children, the etiology shifts from congenital to acquired or systemic. The kidneys were built perfectly fine, but an external force, an immune glitch, or a systemic illness comes along later in childhood and wages war on the tissue.
The list starts with things like chronic glomerulonephritis and chronic pyelonephritis. This sounds like active inflammation and chronic deep tissue bacterial infections.
Yes. Glomerulonephritis is an inflammation of the filtering loops themselves, often triggered by an overactive immune response to an entirely different infection elsewhere in the body. Pyelonephritis is a chronic bacterial infection scarring the meat of the kidney over time.
And actually, before we move on to the systemic diseases, I want to touch on something crucial that ties into those infections. The source material talks about pre-hospital care, specifically the injudicious use of antibiotics. How does what a parent or local clinic does before they reach the hospital impact this?
That's a vital point. In many regions, if a child gets sick or gets a fever, there's a tendency to just hand out broad-spectrum antibiotics without really diagnosing the root cause.
Right, just throwing pills at the problem.
Exactly. And the injudicious use of antibiotics can actually mask the underlying symptoms of these kidney infections. Or worse, some of these drugs are nephrotoxic, meaning they directly damage the kidney tissue themselves. So by the time the child actually gets to a proper pediatric nephrologist, the disease has been simmering and progressing, and the hospital treatment becomes exponentially more difficult because the baseline damage is so much worse.
Wow, so trying to help can actually accelerate the kidney failure if it's the wrong treatment.
Precisely. It really underscores the need for accurate differentials and proper diagnostic workups rather than just guessing.
Okay, so we have the infections, but then we get into the systemic diseases, things that aren't even kidney diseases originally, but they end up destroying the kidneys as collateral damage. Systemic lupus erythematosus, or SLE.
Lupus is the classic autoimmune tragedy. The child's immune system loses the ability to distinguish between foreign invaders and its own tissues. It manufactures rogue antibodies that specifically target the basement membranes of the kidney's filters. The body effectively bombs its own infrastructure.
And sickle cell nephropathy. This is incredibly important to highlight, especially regarding the global data. How does a blood disorder physically destroy a kidney?
We have to look at the sheer physics of the sickle cell trait. Normal red blood cells are supple biconcave discs that can fold and bend to squeeze through the absolute smallest microscopic capillaries in the kidney.
Inflexible.
Very. But in sickle cell disease, under conditions of low oxygen or dehydration, the hemoglobin inside the cell crystallizes. The cell warps into a rigid, sharp sickle shape.
So instead of a flexible inner tube floating down a river, it becomes a rigid, jagged piece of shrapnel.
Exactly. And when hundreds of thousands of these rigid cells try to squeeze into the microscopic filtering beds of the kidney, they cause log jams. They physically block the blood flow. This causes microinfarctions, tiny localized strokes where the kidney tissue dies from a lack of oxygen. Over years, the organ is slowly choked to death by its own blood supply.
That is a brilliant and terrifying mechanical explanation. The presentation rounds out the older etiology with viral infections like HIV and hepatitis, which can trigger immune complexes that clog the filters, and metabolic disorders like cystinosis or hyperoxaluria.
Those metabolic disorders are insidious. They involve genetic enzyme deficiencies where the body cannot break down certain chemicals like the amino acid cysteine or oxalates. Because they aren't broken down, they accumulate in the blood, travel to the kidney, and form sharp microscopic crystals inside the delicate kidney tubules, slicing them open and causing severe inflammation and scarring.
The sheer variety of ways the kidney can be attacked is staggering.
Yeah.
And the source includes broader risk factors, like taking a comprehensive history. This means looking at pregnancy history, birth, nutritional history, and family history, like Alport syndrome, which often pairs progressive kidney failure with severe hearing loss or a history of obesity. If you're listening to this and mentally reviewing your own family's medical history right now, you're doing exactly what pediatricians want you to do. Spotting these patterns is a vital puzzle piece. If there is a family history of Alport syndrome or early unexplained hearing loss, it fundamentally alters the risk profile for a child.
It absolutely does. It commands the pediatrician to go looking for that early stage hyperfiltration long before the child ever acts sick. It changes the entire clinical posture from reactive to proactive, which is the only way to win against CKD.
Okay, so we know the triggers, we know what starts the fire, but here is the most complex and honestly most depressing part of Dr. Igioma's pathogenesis section. Once the damage passes a certain point, the original trigger, whether it was a temporary blockage, an immune flare-up, or a single infection, ceases to matter. The kidney enters a vicious cycle where it actively destroys itself.
It is an autodestructive loop, and to understand it, we must return to that factory analogy in the concept of hyperfiltration. This is the mechanical engine of chronic kidney disease progression.
Let's trace the exact cascade. The initial disease kills 20% of our factory workers. The remaining 80% go into absolute overdrive, working twice as fast. They pull massive amounts of blood into the remaining filters to keep the body's chemistry stable.
The problem lies in the physics of that overdrive. To filter more blood, the tiny afferent arterioles, the hoses feeding blood into the filter, dilate wide open. This exposes the delicate capillaries inside the glomerulus to massive, relentless, high-pressure blood flow. It's like hooking up a high-powered pressure washer to a delicate garden soaker hose.
The hose isn't built to withstand that kind of sheer force.
Exactly. The sheer physical stress of that high-pressure blood flow causes the endothelial cells lining the capillaries to stretch and shear. The physical integrity of the filter literally breaks down under the force of its own compensation.
So the workers are moving so fast and under so much pressure that they are literally breaking their tools and snapping the conveyor belts.
Yes. And as the capillaries tear, the body attempts to heal them by laying down scar tissue. This process is called progressive glomerular sclerosis.
But scar tissue can't filter blood.
No, it cannot. So that specific nephron becomes a solid, useless knot of scar tissue. It dies. Which means our factory, which was down to 80 workers, is now down to 70.
But the body still has the same amount of waste. So the remaining 70 workers have to work even harder, which raises the pressure even more, which causes more shearing, more scarring, and kills off 10 more workers. It is an inescapable, accelerating downward spiral.
It is the ultimate tragedy of human physiology. The kidney destroys itself through its desperate, heroic attempt to maintain homeostasis. But hyperfiltration is not acting alone. The presentation highlights a massive accomplice in this vicious cycle, and that's proteinuria.
We talked about protein in the urine as a marker, a way to diagnose the disease. But the pathogenesis section says the protein itself is a weapon.
This is a major conceptual shift. Normally, the filtering grate of the kidney has a negative electrical charge, which repels large proteins like albumin, keeping them safely in the bloodstream.
Because they're negatively charged too.
Right, like magnets repelling each other. But as the high-pressure hyperfiltration damages the filter, the holes get bigger and the negative charge is lost. Massive proteins slip through and crash into the proximal tubules, which are the delicate drainage pipes below the filter.
And protein isn't supposed to be in those pipes.
It is completely alien there. The cells lining the tubule panic. They attempt to reabsorb this massive influx of protein, but it overwhelms their internal machinery. The lysosomes inside the cells rupture, spilling toxic enzymes. Even worse, the presence of these proteins acts like a chemical flare gun, signaling the immune system that something is terribly wrong.
A false alarm.
A massive false alarm. The tubule cells release inflammatory cytokines, attracting immune cells like monocytes and macrophages. These immune cells flood the interstitial spaces, the tissue between the tubes, and start releasing destructive enzymes and fibrotic factors, attempting to fix an infection that doesn't actually exist.
So the protein slipping through the broken filter essentially buns the surrounding tissue, triggering an immune response that lays down even more scar tissue, tubulointerstitial fibrosis.
Precisely. And if you add systemic hypertension to this, which is another driver listed in the source, the damage accelerates exponentially. Systemic high blood pressure batters the walls of the tiny blood vessels feeding the kidneys, causing the muscular walls to thicken and narrow, a process called arteriolar nephrosclerosis.
It's like the pipes calcifying and choking off the blood supply. And the final accomplice in the pathogenesis cycle is hyperphosphatemia, high phosphate in the blood. How does that accelerate the scarring?
Well, as the kidney fails, it loses the ability to excrete dietary phosphate. The levels in the blood rise. This excess phosphate actively binds with the calcium in the bloodstream. The resulting compound, calcium phosphate, is essentially microscopic limestone.
Whoa.
Yeah, and this limestone deposits directly into the soft tissue of the renal interstitium and inside the walls of the blood vessels. The kidney is quite literally calcifying, turning to stone from the inside out.
That cascade of destruction, hyperfiltration pressure, protein burning the tubules, high blood pressure choking the vessels, and phosphate turning the tissue to stone paints a horrifying picture. The kidney is systematically dismantling itself.
It really is.
And that leads us into the most overwhelming section of Dr. Igioma's entire presentation. Because the kidneys are the central chemical balancing plant, the water reservoir, and the hormonal factory, their total collapse doesn't just mean a localized ache in the back. It triggers a systemic meltdown of almost every major organ in the child's body.
The clinical features and pathophysiology of pediatric CKD represent a total failure of homeostasis. The presentation outlines 17 specific systemic manifestations. It really requires us to trace the journey of a single toxic drop of blood as it navigates a child's failing biology.
I want to spend significant time unpacking the cause and effect of these 17 manifestations, because if you don't understand the systemic fallout, you don't understand the disease. Let's start with the immediate chemical and fluid imbalances. Manifestation number 1, azotemia.
Azotemia is the accumulation of nitrogenous waste products, specifically urea and creatinine in the blood. The mechanism is simple. The GFR has collapsed. The filters are plugged with scar tissue. The waste products that should be flowing into the bladder are trapped in the circulatory system. The child's blood is becoming a toxic swamp.
And as that toxic blood circulates, we hit manifestation number 2, acidosis. The blood literally becomes acidic. We touched on this earlier, but explain the dual failure happening here.
First, the damaged tubules lose their ability to reabsorb bicarbonate. Bicarbonate is the base that neutralizes acid, right? So the kidney is essentially leaking the body's internal antacid directly into the toilet.
Oh, man.
Second, a healthy kidney actively synthesizes ammonia, which acts as a chemical sponge to soak up and excrete daily metabolic acids. The scarred kidney stops making ammonia, so the body loses its neutralizing base and loses its mechanism for pumping out daily acid. The pH of the blood plummets.
The blood turning acidic alters the function of every single protein and enzyme in the body. It's a cellular disaster. Then we move to the fluid dynamics. Manifestation 3 is sodium retention.
This brings us back to the endocrine failure. The dying, oxygen-starved kidney tissue panics and releases massive amounts of the hormone renin. The renin cascade screams at the remaining tubules to hoard sodium, convinced the body is suffering from low blood volume. Where sodium goes, water follows. The child's body begins to aggressively retain fluid, leading to severe whole-body swelling or edema.
But paradoxically, manifestation number 4 is a urinary concentrating defect, meaning the child is entirely incapable of concentrating their urine. If the body is aggressively retaining sodium in water, why are they peeing out dilute fluid?
It relates to the intense hyperfiltration of the surviving nephrons. The few workers left on the factory floor are dealing with such an overwhelming flood of urea and waste that it causes an osmotic diuresis. The sheer volume of waste dragged through the remaining tubes literally pulls water along with it, moving too fast for the kidney to concentrate it.
So it just rushes right through.
Exactly. Furthermore, the internal scarring destroys the delicate concentration gradient deep in the kidney's medulla. So the child might pee large volumes of water, risking severe dehydration, even while their total body sodium is dangerously high.
The system is completely deregulated.
Yeah.
And manifestation 5 is arguably the most immediately lethal chemical imbalance. Hyperkalemia, dangerous levels of potassium.
Potassium is a widowmaker.
Explain that.
Well, the electrical rhythm of the human heart relies on a highly precise ratio of potassium inside and outside the cells. When the GFR drops, the kidney simply cannot excrete dietary potassium. Even worse, That severe acidosis we just discussed causes a chemical shift, forcing potassium out of the body's cells and dumping it into the bloodstream.
So a child eats a banana, and because their kidneys can't clear the potassium, it builds up in the blood until it literally shorts out the electrical system of the heart, causing fatal arrhythmias.
Exactly. It is a constant looming threat of sudden cardiac arrest.
Let's shift from the acute chemical dangers to the devastating developmental impacts. Manifestations 7 and 8 are renal osteodystrophy and growth retardation. If you look at a child with advanced CKD, they're often dramatically shorter than their peers, and their skeleton is deteriorating.
The growth retardation is a deeply complex multifactorial failure. The child is suffering from protein-calorie malnutrition because the toxic uremic blood makes them intensely nauseated. They literally cannot eat. The chronic acidosis directly stunts bone mineralization. The anemia starves their growing tissues of oxygen.
And the presentation explicitly mentions growth hormone resistance.
Yes. The child's pituitary gland might be pumping out normal levels of growth hormone, screaming at the body to grow, but the uremic toxins floating in the blood alter the cellular receptors. The tissues become deaf to the hormone. The signal is sent, but it is never received.
And then there's the renal osteodystrophy, the bone disease. This is where the endocrine failure of vitamin D becomes catastrophic.
Without the kidney to activate vitamin D, the child's intestines lose the ability to absorb calcium from their food. Calcium levels in the blood begin to free fall. The parathyroid glands in the neck sense this drop, and they panic.
What do?
They release parathyroid hormone, which acts as a demolition crew. It travels to the child's skeleton and forces the bones to dissolve, releasing their stored calcium into the bloodstream to keep the heart and nerves functioning.
So to survive the next hour, the body literally cannibalizes its own skeleton. The bones become soft, deformed, and incredibly painful.
It is a horrific trade-off forced by a failing biology.
And the systemic collapse continues into the circulatory system. Manifestation 9 is anemia. And reading the mechanisms here, it is a multi-front war against the red blood cells.
The primary blow is the failure of the endocrine factory. The scarred kidney stops producing erythropoietin. The bone marrow receives no signal, so it shuts down production of new red blood cells. But the tragedy compounds. The high levels of uremic toxins in the blood create a hostile environment that causes low-grade hemolysis.
Hemolysis means
The existing red blood cells are physically battered and destroyed faster than normal.
so they aren't making new blood, and the toxic swamp is dissolving the blood they already have.
Add to that the fact that uremia severely impairs platelet function, meaning the child bruises easily and suffers from microbleeding in the gut, literally bleeding out their remaining red cells. And finally, their severe nausea prevents them from absorbing the iron and folate needed to build new ones. It is profound, suffocating anemia.
Which explains the overwhelming fatigue. But that lack of oxygen doesn't just make the child's muscles tired. It starves the most oxygen-hungry organ in the body, the brain. Which leads us to manifestation 12, the neurological symptoms. The list includes drowsiness, memory loss, slurred speech, seizures, and coma. The brain is actively shutting down.
The central nervous system is being assaulted from 3 directions. First, the uremic toxins, the urea and creatinine, readily cross the blood-brain barrier, directly poisoning the neurons. Second, the severe water retention and high blood pressure cause hypertensive encephalopathy. The brain literally swells inside the skull, crushing its own tissue.
And third, the source material points out a highly specific iatrogenic cause, aluminum toxicity. Iatrogenic meaning caused by the medical treatment itself. How are doctors accidentally poisoning children's brains?
It is a dark chapter in nephrology. Remember the hyperphosphatemia, the excess phosphate turning the kidney to stone?
Yeah, the microscopic limestone.
Historically, and still in under-resourced areas, doctors gave patients oral aluminum hydroxide. The aluminum acts as a binder. It grabs the phosphate in the gut so it can be pooped out. It solved the phosphate problem. But small amounts of that aluminum are absorbed into the blood. A healthy kidney excretes it instantly. A failing kidney traps it. The aluminum steadily accumulates, crosses the blood-brain barrier, and binds to the brain tissue, causing a devastating condition known as dialysis dementia, profound cognitive decline, speech arrest, and fatal seizures. We poison the brain to save the bones. Modern medicine uses non-aluminum binders now, but the historical scar remains on the protocol.
The margin for error is non-existent. You try to fix one broken lever, and 3 others snap. Moving down body, manifestation 13 is gastrointestinal ulceration. Why is the kidney problem burning holes in the child's stomach?
The mechanism is gastric acid hypersecretion. The buildup of uremic toxins disrupts the feedback loops that regulate the hormone gastrin. The stomach receives a continuous faulty signal to pump out highly concentrated hydrochloric acid. The stomach lining cannot defend against this constant acidic deluge, resulting in painful, bleeding ulcers.
Which feeds right back into the anemia and the malnutrition. Then we have the cardiovascular collapse. Manifestation 14 is hypertension driven by the renin overdrive and the massive retention of sodium in water. But manifestation 16 is pericarditis and cardiomyopathy. The heart muscle itself begins to fail.
The heart is a pump. If you force a pump to push thick, toxic fluid against incredibly high pressure, the systemic hypertension 24 hours a day, the muscle wall thickens, stiffens, and eventually dilates and fails. That is the cardiomyopathy. The pericarditis is an inflammation of the sac enclosing the heart, caused by those uremic toxins acting as a direct chemical irritant to the lining, causing severe chest pain and fluid accumulation around the heart.
In wrapping up this overwhelming list, the presentation notes metabolic and immune failures. Hypertriglyceridemia, because the uremic blood disables the enzymes that break down fat in the bloodstream. Glucose intolerance, because the tissues become deaf to insulin. And finally, number 11, infection.
The immune system is profoundly suppressed. The uremic environment causes defective granulocyte function.
Granulocytes
They are the white blood cells that act as your frontline infantry against bacterial invaders. In a uremic child, these cells are paralyzed. They cannot navigate to the site of an infection, and they cannot consume the bacteria. The cellular immune cascade is silenced, leaving the child completely vulnerable to everyday pathogens.
I am taking a deep breath here, because digesting the reality of those 17 systemic failures is staggering. The child's blood is acidic, their bones are dissolving, their brain is poisoned, their heart is failing, and their immune system is offline.
It's a total systems failure.
So with all of this catastrophic internal chaos, how does it physically manifest to a parent or a pediatrician? If you are in the examination room, what is the history and physical exam telling you? Because early detection relies on recognizing these signs before it's too late. We have to discuss differentials too, like what questions are doctors asking to rule out other conditions?
Right. The clinical presentation is heavily dictated by the age of the child and the underlying cause. Gathering the history for an infant requires looking for entirely different clues than questioning a 10-year-old. And forming that differential diagnosis means asking about recent strep infections, medication use, or family history of things like PKD to rule out acute versus chronic issues.
Let's start with the infants. What are the subtle, early signs in a baby under a year old?
Well, infants cannot complain of bone pain or nausea. The history is often vaguely terrifying for a parent. They will report a general failure to thrive. The baby isn't gaining weight, their growth percentiles are dropping, and they show poor feeding. The pediatrician will note severe pallor due to the creeping anemia.
But the presentation specifically highlights dribbling of urine. That sounds like a neon sign for the congenital blockages we discussed.
It is the defining mechanical symptom of conditions like posterior urethral valves. A healthy infant produces a strong, forceful, intermittent stream of urine. If the urethra is blocked by those abnormal flaps, the bladder is fighting a losing battle.
So it doesn't stream.
No, it just constantly, weakly dribbles out under immense back pressure. If a parent reports dribbling, the pediatrician must immediately suspect obstructive uropathy, tearing the kidneys apart upstream.
So that is the mechanical clue in infants.
Yeah.
What about the older children? The ones suffering from the acquired diseases like lupus or glomerulonephritis?
The history of an older child is a direct reflection of the systemic meltdown we just spent 20 minutes unpacking. The chief complaint is often profound, unexplainable tiredness, directly linked to the anemia. Parents will notice their 8-year-old still wears clothes meant for a 5-year-old, highlighting the growth retardation. They will complain of long-standing, intractable nausea and vomiting, driven by the uremic stomach ulcers.
And fluid issues. The source mentions on and off body swellings or edema, and strangely, it lists excessive thirst and polyuria peeing massive volumes right alongside reduced urine output. How do you have a history of both?
It represents the timeline of the failing nephrons. Early on, the hyperfiltering damaged kidneys lose their ability to concentrate urine. The child pees massive volumes of water polyuria, which triggers desperate, excessive thirst to avoid dehydration.
Right, because the water is just flushing through.
Exactly. But as the disease progresses to stage 4 and stage 5, and the nephrons finally scar over and die, the filtration grinds to a halt. the urine output plummets. So the history involves a period of excessive urination followed by a terrifying cessation of output.
That makes perfect sense. Now, there is one highly specific and fascinating symptom on Dr. E. Gioma's list for advanced uremia: hiccups. Intractable hiccups. How on earth does a dying kidney cause a hiccup?
It is one of those bizarre, critical clinical pearls. A hiccup is an involuntary spasm of the diaphragm muscle. When the kidney completely fails, the concentration of urea and other toxins in the blood reaches astronomical levels.
And those toxins affect the muscles.
They chemically irritate the vagus nerve and the phrenic nerve, the exact neural wiring that controls the diaphragm. Furthermore, the severe uremic gastritis irritates the stomach lining right beneath the diaphragm.
So the poison nerves are just misfiring wildly.
Exactly. Intractable, exhausting hiccups in a chronically ill child is a blaring neurological alarm bell. It means the brain and the nerves are swimming in toxic waste.
Wow. So the history paints a grim picture. The doctor moves to the physical examination. What do they find when they put their hands and their stethoscope on the child?
The physical signs confirm the systemic collapse. They will note the severe waxy pallor of the skin. They will take the blood pressure and find severe hypertension far beyond normal pediatric ranges. But the respiratory exam reveals something very specific: acidotic breathing.
Kussmaul breathing. I've read about this in diabetic emergencies, but how does it relate here?
It is the exact same physiological compensation. The blood pH has dropped into a dangerously acidic range because the kidney isn't making bicarbonate. The body is desperate to lower the acid load. Carbon dioxide in the blood acts as a mild acid.
Okay, so the body tries to breathe out the acid.
Precisely. The respiratory center in the brain orders the lungs to hyperventilate. The child will exhibit deep, rapid, labored, gasping breaths, not because their lungs are failing, but because they are desperately trying to exhale the acidic carbon dioxide to compensate for the kidney's failure.
It is horrifying to watch a child gasping for air just to balance their blood chemistry. And then there are the skin manifestations. The source lists severe pruritus, relentless itching caused by calcium and phosphate depositing in the skin, and easy bruising from the platelet dysfunction. But the most chilling physical finding listed is uremic frost.
Uremic frost is a finding from the darkest depths of end-stage renal disease. It is something you rarely see in areas with modern dialysis, but it paints a vivid picture of total metabolic failure. The skin is technically an accessory excretory organ. We excrete trace amounts of waste in our sweat.
Right.
When the kidneys shut down entirely, the blood concentration of urea becomes incredibly massive. The body, in a last-ditch effort, attempts to sweat the urea out. The sweat glands pull the urea from the plasma and push it onto the skin. When the sweat evaporates, the pure urea crystallizes.
That's the frost.
Yes, it leaves a thick, white, powdery, frost-like coating on the child's face, neck, and chest.
They're literally sweating out the toxic waste their body can no longer filter, and it just crystallizes on their skin.
Yeah.
That is a visual that fundamentally underscores the severity of this illness.
It represents a body that has exhausted every single physiological avenue of survival.
This brings us to the crucial turning point. The pediatrician takes the history, sees the pallor, hears the Kussmaul breathing, and suspects CKD. How do they scientifically confirm it? How do they measure the exact stage of the destruction? We must look at the laboratory diagnosis.
The laboratory investigations are how we shift from suspicion to hard data. The source breaks this down into essential tests, starting with the urine.
The urinalysis.
Yes, a simple dipstick can immediately detect the presence of blood, or more importantly, protein. They will also run a urine MCS microscopy, culture, and sensitivity to look for bacterial infections, and examine the urine under a microscope for cellular casts, which are essentially molds of dead cells flushed from the dying tubules.
And the blood tests, the serum investigations.
The serum tests map the systemic fallout. They draw on E, U, and CR electrolytes, urea, and creatinine. This tells them exactly how high the nitrogen waste is and reveals if the potassium has reached that fatal, heart-stopping level. They measure calcium, phosphate, and alkaline phosphatase to assess how rapidly the skeleton is dissolving.
Checking all the systems.
Right. They draw a complete blood count to measure the depth of the anemia and run a lipid profile because the triglycerides are likely soaring.
But Dr. E. Gioma's presentation elevates two specific metrics as the gold standards for tracking and staging the disease. The first is a metric for proteinuria, the UPCR. Now, we spent a long time establishing that protein slipping through the filter is a weapon that burns the kidney tissue. Measuring how much protein is leaking is vital. How do they do that in a child?
Historically, quantifying protein leakage was a logistical nightmare. You had to perform a 24-hour urine collection. You had to give the parent a large jug and instruct them to catch every single drop of urine the child produced for a full day and night.
Which is completely impossible if a patient is a 2-year-old in diapers.
It is highly prone to error. What the presentation emphasizes as the modern gold standard is the UPCR, the urine protein to creatinine ratio. It is an elegant mathematical solution to the 24-hour problem.
How does the math work?
You only need a single random spot sample of urine. It doesn't matter what time of day it is or how much volume there is. The lab measures the concentration of protein in that sample, and they measure the concentration of creatinine in that exact same sample. Because creatinine is excreted into the urine at a very steady, constant rate throughout the day, it acts as a baseline reference.
So you just divide the protein number by the creatinine number.
Exactly. The ratio between the two provides a highly accurate estimate of what the total 24-hour protein leak would be. A normal UPCR is less than 30 milligrams of protein per gram of creatinine. If that ratio jumps to 300 or 1,000, the pediatrician instantly knows the filters are structurally compromised and the tissue is burning. It changes the game for early, accurate detection.
That is a massive clinical relief, replacing a 24-hour jug with a simple math equation. But the second gold standard, the glomerular filtration rate, the GFR speedometer, involves a nuance that is absolutely vital for pediatricians to understand. The presentation dedicates a whole slide to how normal GFR changes based on the child's exact age.
This is the most critical pitfall in pediatric nephrology. You cannot take adult laboratory reference ranges and apply them to a child. A child is not a miniature adult. Their kidneys are rapidly developing, maturing, and ramping up their filtration capacity long after birth. The speedometer is a moving target.
Walk me through the numbers provided in the source, because the jump in filtration power is wild.
According to the data, a 1-week-old infant has a mean GFR of just 40.6.
Wait, 40.6. We established earlier that stage 3 moderate kidney damage is a GFR between 30 and 59.
Precisely. If an adult or a 10-year-old has a GFR of 40, they are in profound renal failure. But for a 1-week-old infant, 40 is perfectly flawlessly normal. The fetal nephrons are just beginning to handle the blood volume independently from the placenta.
How fast does it ramp up?
Rapidly. By 2 to 8 weeks of age, the mean GFR climbs to 64.8. Over 8 weeks, it hits 95.7. And by the time the child is between 2 and 12 years old, the mean GFR stabilizes around 130.
So if a pediatrician draws a lab test on a 3-week-old baby, and the computer system, which might be calibrated for adults, flags a GFR of 50 as severe kidney disease, the doctor needs to know to ignore the red flag.
Yes, they must strictly contextualize every single lab result against the child's exact chronological age. A static blood test measuring creatinine is utterly useless unless the physician calculates the estimated GFR using pediatric-specific formulas, which factor in the child's height, age, and sex. Misinterpreting these numbers leads to either tragic misdiagnoses or unnecessary medical panic.
The diagnostic landscape requires immense precision. Okay, so the pediatrician has run the labs, they've calculated the age-adjusted GFR, they've run the UPCR, they've definitively diagnosed a 6-year-old child with stage 3 chronic kidney disease. What happens next? Because from everything we've discussed about the pathogenesis, the vicious cycle of hyperfiltration and scarring the native kidney tissue cannot regenerate. The goal isn't a cure, is it?
No. And that is the hardest conversation a nephrologist will ever have with a family. The scarring, the glomerulosclerosis, and the interstitial fibrosis is permanent. The overarching goal of the management strategy is twofold. Violently halt the progression of the disease to preserve the remaining nephrons and medically manage the massive fallout of those 17 systemic manifestations to keep the child growing.
The source outlines a multidisciplinary approach. It's not just prescribing a pill, it involves nephrologists, dietitians, endocrinologists, and psychologists. The first objective is to treat the primary cause, if possible.
Which means if the child has a posterior urethral valve, a pediatric surgeon must immediately resect that blockage to relieve the pressure. If the cause is lupus, you deploy heavy immunosuppressants to stop the friendly fire. But beyond the primary cause, the mandate is to control the accomplices driving the hyperfiltration cycle.
The presentation explicitly says control hypertension and abort proteinuria. How do you abort the protein leak?
You have to lower the pressure inside the factory. Nephrologists use specific classes of blood pressure medications, like ACE inhibitors or ARBs. These drugs don't just lower systemic blood pressure, they specifically dilate the exit hose of the glomerulus. By widening the exit, the massive internal pressure drops.
Like taking your thumb off the end of the garden hose.
Exactly. The pressure drops, the physical shearing force on the capillaries decreases, and the protein stops being forced through the broken grate. It slows the scarring process down significantly.
And what about managing that systemic developmental fallout, the bones dissolving and the severe anemia?
The medical intervention here is exhaustive. Because the kidney cannot make erythropoietin, the child is given synthetic recombinant EPO injections. The dosage is very specific, usually between 50 and 150 milligrams per kilogram, to artificially stimulate the bone marrow to make blood.
Replacing the hormone factory piece by piece.
Yes. They treat the bone disease by aggressively managing the diet. The child is placed on severe dietary restrictions: low salt to fight the fluid, low phosphate to stop the calcification, and low potassium to prevent cardiac arrest. Navigating that diet for a growing toddler is an immense psychological burden for parents. To bypass the vitamin D failure, they prescribe active vitamin D supplementation between 800 and 1,200 international units daily to force the intestines to absorb calcium again.
And for the severe growth retardation, the fact that the uremic blood makes them resistant to their own growth hormones.
They fight biology with pharmacology. They administer massive doses of recombinant human growth hormone, attempting to overwhelm the uremic resistance by sheer chemical volume, forcing the long bones to grow. They even deploy HMG-CoA reductase inhibitors, which the general public knows as statins.
Wait, statins? Like the cholesterol drugs adults take to prevent heart attacks.
Yes, because the uremic environment causes profound dyslipidemia, high cholesterol, and triglycerides, which further damages the blood vessels. The doctors are quite literally fighting fires in the skeletal, circulatory, endocrine, and cardiovascular systems simultaneously.
But despite the ACE inhibitors, the synthetic hormones, the strict diets, and the statins, the disease is progressive. Eventually, in many cases, maximal medical management is simply no longer enough. The remaining workers collapse. The child progresses to stage 5.
End-stage renal disease. ESRD.
How does Dr. Ijeoma define the reality of ESRD?
The source defines ESRD as the state in which a patient's renal dysfunction has progressed to the point at which homeostasis and survival can no longer be sustained with native kidney function. The body has lost the war, it can no longer clear the acid, it cannot excrete the fatal potassium, and it cannot filter the uremic toxins regardless of the drugs you administer.
And that brings us to renal replacement therapy, or RRT, artificial life support. The presentation stresses that planning for RRT must begin long before the child hits stage 5. It says preparation should start at stage 4. Why the early runway?
Because initiating mechanical dialysis or securing an organ transplant requires massive logistical and surgical groundwork. You cannot wait until a child is in an active uremic coma to start looking for a kidney donor. You need time to surgically create a vascular access point in the child's arm, a fistula, so the dialysis machines can pull the blood out at high speeds.
But having a plan is different than pulling the trigger.
Yeah.
What are the clinical alarm bells? When does the multidisciplinary team look at a child and say, medical management is officially over? Today, we attach them to the machine.
The clinical triggers for initiating dialysis are absolute emergencies. The presentation lists refractory fluid overload, meaning the child is drowning in their own retained fluid, their lungs are filling up, and heavy diuretics are doing nothing. Severe, unmanageable acidosis that oral bicarbonate cannot fix.
And the widowmaker.
Severe hyperkalemia. If the potassium is climbing toward fatal levels despite dietary restriction, you must dialyze to clean the blood before the heart stops. Other triggers include profound irreversible growth failure or the onset of end-stage uremic symptoms like the pericarditis we discussed, or the neurological onset of intractable hiccups and seizures.
The presentation compares a few modalities of this artificial life support. It notes that high-intensity home hemodialysis offers better survival and a significantly greater quality of life compared to conventional 3 times a week in-center dialysis or peritoneal dialysis. But the machine is just a bridge, isn't it?
Dialysis is a brutal, exhausting existence for a child. It keeps them alive, but it does not replace the endocrine functions, and it heavily restricts their childhood. The ultimate goal, the only true long-term solution that comprehensively restores the chemical plant, the hormonal factory, and the water management, is renal transplantation.
Receiving a healthy, functioning kidney from a living or deceased donor, which instantly ends the hyperfiltration cycle, restores the EPO, and clears the toxins.
Yes. Transplantation significantly increases survival and developmental outcomes compared to endless dialysis.
Which brings us to the final, most sobering part of Dr. Ijeoma's entire presentation. We have spent an hour discussing incredible complex medical interventions, recombinant hormones, statin protocols, surgical fistulas, high-intensity dialysis machines, and organ transplants. But the conclusion of the source material abruptly shatters the illusion that these miracles are available to everyone.
The prognosis of pediatric CKD is profoundly dictated by geography. The epidemiological data is unforgiving. Mortality strictly increases as kidney function decreases. But the context of Dr. Ijioma's slides, which were developed regarding the healthcare reality in Nigeria and similar developing nations, recontextualizes everything we just discussed.
The slide explicitly states that early diagnosis and treatment are exponentially more urgent in developing countries. Not just important, urgent. Why?
Because, as the author painfully notes, in these regions, the facilities, the specialized pediatric nephrologists, and the financial capacity for long-term pediatric dialysis and renal transplantation are almost non-existent.
Almost non-existent. There is no high-intensity home hemodialysis machine waiting for a child in a rural clinic. There is no national computerized transplant registry.
Exactly. The safety net that Western medicine relies upon for ESRD simply does not exist there. If a child in these regions progresses to end-stage renal disease, it is not a transition to artificial life support. It is an active, rapid death sentence.
Which makes the entire concept of early detection a literal matter of life and death. Spotting the dribbling urine in a newborn, running a UPCR to catch the microscopic protein leak, contextualizing the GFR to realize a 10-year-old is in stage 2, that isn't just about managing a chronic illness. It is about aggressively halting the progression at stage 3, because stage 5 is unsurvivable.
The mandate is absolute vigilance. You must control the blood pressure and abort the proteinuria while the child still has functioning nephrons. The knowledge we've discussed today is the only viable weapon in resource-limited settings.
It is a devastating reality check. It transforms this presentation from a dry clinical outline into a desperate roadmap for survival. To summarize the immense journey we've navigated today, pediatric chronic kidney disease is not just a localized organ issue. It is a catastrophic systemic collapse of the body's entire chemical, fluid, and hormonal foundation. It is triggered by congenital plumbing errors in the womb or vicious systemic and genetic attacks later in childhood. It drives a fatal loop where the surviving nephrons physically destroy themselves through high-pressure hyperfiltration just to keep the blood clean.
It's just a tragic cascade.
It manifests in a horrifying array of symptoms, from dissolving bones and poisoned brains to Kussmaul breathing and uremic frost. It demands precise age-adjusted diagnostics and relentless medical intervention to slow the scarring, because for millions of children globally, the end stage is a point of no return.
It represents one of the most profound clinical challenges in pediatrics. But mapping the exact mechanisms of the disease, as Dr. Ijeoma has done, is the only way to successfully ambush it.
Absolutely. And as we close out this deep dive, I will leave you with a thought that has been echoing in my mind since we started unpacking the mechanism of hyperfiltration. We spent a lot of time analyzing how the kidney desperately tries to save the body by forcing its remaining healthy cells to work themselves to literal death. The sheer force of that heroic compensation is what ultimately tears the organ apart.
Yeah.
It makes you wonder, if hyperfiltration is essentially a survival mechanism pushed violently past its breaking point, how much of what we medically label as a chronic disease is actually just the body's own brilliant, desperate adaptations eventually destroying the vessel they were trying to save? In a fight for homeostasis, are we battling an invading disease, or are we ultimately just trying to save the body from its own relentless work ethic?
That is a profound question.
It's a perspective that completely changes how you view the fragility of the human machine. Something to mull over. Thank you for joining us on this incredibly heavy, deeply informative dives into the source material. We'll catch you on the next one.